Assalamu alaikum everyone. My name is Hala Sammour. I'm fourth year medical student, and today, inshallah, I'll be presenting you the OSPE part of your EndoRepro block. I've tried to add every single picture that is found in your patho, clinical, micro, and radiology lectures. Not only that, but I've added a couple of points on each picture so that, inshallah, it would be a good review for your MCQs and also for your OSPE. Without any further ado, let's get started. So we'll talk first about the endocrine section, patho, and clinical lectures. Okay, so starting off with the pituitary adenoma. So pituitary adenoma is basically a benign tumor of the pituitary gland. As you can see over here, this is a pituitary adenoma of a larger size, and here is a smaller one. As you can see, this was supposed to be a normal stalk, but there is a tumor. It's the most important and aggressive genetic changes are those four. So we have TP53 mutation, increased in cyclin D1, RB silencing, and increased Ki67, and it's also associated with MEN1 syndrome. Those are the histopathology of pituitary adenoma. Next, we have a prolactinoma, which is a subtype of the adenoma. Here we have the sparsely granulated prolactinoma. As you can see, the granules are sparsely located, and that's where it gets its name from. And here we have the densely granulated prolactinoma. This is more dense, so more vesicles that contain the hormone. And this is the most common functional pituitary adenoma. So sometimes we have pituitary adenomas that do not produce any effects, right? However, the prolactinoma is usually functional. So it causes visible effects. Features, they're chromophobic cells with frequent amyloid and microcalcifications. Next, we have craniopharyngioma. Again, this is a benign tumor. However, this tumor is in the suprasellar region. It's not in the pituitary gland itself. It's above the pituitary gland in the suprasellar region, which originates from the Rathke's pouch. It usually occurs in children, which are 5 to 15 years of age, and in very old adults that are from 60 to 70 years of age. It has two types, the adamantimatous, which is found in children, and the papillary, which is found usually in adults. This is the picture of the craniopharyngioma. And again, this is the picture on an MRI. As you can see, it's not at the pituitary stalk, but it's above it, at the suprasellar region. Memorize this picture, please. Stalk effect. So basically, this is an effect that occurs due to the compression on the pituitary gland. So we have an external compression on the pituitary stalk that is going to decrease the effect of dopamine and increase prolactin. Here we have acromegaly, or basically, which is basically a macroadenoma that causes increase in growth hormone and IGF-1. IGF-1 is basically the hormone, or it's the thing that produces the effect that we're going to discuss right now. In children, it causes gigantism, and in adults, it causes acromegaly, which basically causes the coarse facial features, the enlarged hands and feet, as you can see over here, and the increased feet pad. Heel pad, sorry. Yes, the increased thickness of the heel pad. Of course, a sign is also spontaneous thickening, so spontaneous sweating, sorry. Okay, for the diagnosis, we can measure IGF-1, which is going to be increased. We will have failed GH suppression with the OGTT, or the oral growth hormone test. And we have, on the MRI, we're going to see a macroadenoma. It's important to note that cardiac disease is the most common cause of death in those patients. Next, we have Cushing's syndrome, which basically can occur due to multiple causes. The most common cause is iatrogenic, which is basically an external use of glucocorticoids. The second most common cause is basically an ACTH-producing pituitary adenoma. So we have a tumor in the pituitary that is producing ACTH, and this is basically a subtype of Cushing syndrome called Cushing disease. Okay, next we have the adrenocortical carcinoma that causes Cushing syndrome. So here we have a tumor in the adrenal gland that is going to produce the effects of the hormone. How do those patients present? So we're going to have moon faces, hirsutism, acne, and striae, as you can see over here. First line, we need to have 2 out of 3 of these positive. Dexamethasone suppression test, midnight salivary cortisol, and 24-hour urinary free cortisol. So this is the adrenocortical tumor that is causing Cushing syndrome. And here we have an ectopic ACTH. So basically an ectopic tumor that is producing the ACTH hormone. There is this test called the IPSS. It basically differentiates Cushing's disease from ectopic Cushing's syndrome. How is that? It's an invasive kind of procedure that measures the ACTH hormone directly from the pituitary gland. If it was high, this means this is a Cushing's disease. If it was not high, this shows that the origin of the ACTH is not from the Cushing, not from the pituitary, sorry. Next we have Kallman syndrome, which is basically a case of hypogonadotropic hypogonadism plus loss of smell. This is the typical picture of those patients, and they have loss of smell. Why do they have loss of smell? That's because of the degeneration of the olfactory bulb. As you can see, this is a normal bulb here. It should be enhancing this way. Here we have the loss of the olfactory bulb, and that's why they have the loss of smell. So basically, it occurs due to a CAL1 gene mutation, failed migration of the GnRH neurons. That's why it's called hypogonadotropic hypogonadism. So basically, we have decrease in GnRH and decrease in LH and FSH. Presentation, delayed puberty, primary amenorrhea, and anosmia, which is basically the loss of smell. And there is this typical feature of Kallman syndrome, which is the bimanual synkinesia, which is basically the patient cannot move each hand alone. They have to move them both together. It's like they're synced, kind of. Next, we have diabetes insipidus. It could be due to two causes, either central or nephrogenic. In the central kind of diabetes insipidus, we have decreased ADH, and that's because of the pituitary. As you can see here on the MRI, we have the loss of enhancement of the posterior pituitary, showing that the problem is from the pituitary itself, and this is called central diabetes insipidus. The nephrogenic is basically kidney resistance to ADH. Next, we have the lymphocytic hypophysitis, which is basically an autoimmune inflammatory disorder that is attacking the pituitary gland and again causing decrease in ACTH and ADH hormone. And this usually occurs postpartum. This is the picture for it. Just remember the picture, nothing much. Next, we have meningioma. Here we have just the growth of the meninges. Now for the thyroid, this is how a normal thyroid gland should look like. It's lined by cuboidal, a single layer of cuboidal cells that can become columnar when they are active and producing the hormone. And as you can see, they're filled with colloid that store the thyroglobulin. What is hyperthyroidism? It's basically a case where we have increased thyroid hormones. Those produce those symptoms, including tachycardia, palpitations, AFib, tremor, lid lag. As you can see over here, this is a lid lag. And what is lid lag? It's basically when the patient looks down, their upper eyelid does not cover their pupil. It stays at the back. So it's basically a lid lag. And oxophthalmos over here. Causes Graves' disease, toxic multinodular goiter, and sometimes a toxic adenoma. Here we have hypothyroidism, which is a decrease in the thyroid hormones. It could be due to Hashimoto thyroiditis, iodine deficiency, thyroidectomy, or thyroid dysgenesis, which have these gene mutations, or even to drugs. In children or in congenital diseases, it causes cretinism, which is basically an intellectual disability, short stature, coarse face, and umbilical hernia. In adults, it can cause mixed edema, which is the typical non-pitting edema finding that is found in hypothyroidism. Hashimoto thyroiditis, this is the most common cause of hypothyroidism in iodine-rich countries. It's basically painless, symmetric, and diffuse enlargement of the thyroid gland. It's autoimmune. What are the most important antibodies? And anti-TPO and anti-thyroglobulin. On histology, we have Hürthle cells. So these are Hürthle cells that are typical in Hashimoto thyroiditis. Please memorize the Hürthle cells picture and the Hashimoto thyroiditis picture. Next, we have subacute granulomatous thyroiditis. This picture is very important. It's called de Quervain thyroiditis. Please do not mind the way I'm pronouncing those. I'm not sure if it's correct. Just bear with me. So this is kind of, again, degeneration of the thyroid gland that happens after a viral upper respiratory infection. So they're going to give you a 10-line scenario with a patient that had a viral upper respiratory tract infection, and suddenly he's having a painful thyroid, and you have this picture attached as well. What's the diagnosis? De Quervain thyroiditis or subacute granulomatous thyroiditis. On the contrary, we have subacute lymphocytic thyroiditis, which is painless. This is autoimmune again. This is a painless kind of hyperthyroidism, but this time this occurs after giving birth. So this happens postpartum. So painless, that occurs postpartum with lymphocyte aggregation, as you can see in this picture. This is subacute lymphocytic thyroiditis. Here we don't have lymphocyte aggregation. It's we have granulomas. طيب. Next, we have radial thyroiditis. I hope I'm pronouncing that correctly. In radial thyroiditis, we basically have a rock-hard, painless neck mass. So this is a keyword that you're going to get in the scenario. Rock-hard, painless neck mass. It is composed of fibrosis. There is dense fibrosis. And this is the picture that you're going to have. As you can see, the fibers are very clear. These are the fibers, and this is the lymphocytic infiltration, the inflammatory cells. This is radial thyroiditis, and it usually occurs in young patients. Next, we have Graves' disease, which again is a cause of hyperthyroidism in young women. It could be due to a toxic diffuse goiter as well. It comes with a triad, so an hyperthyroidism, infiltrative ophthalmopathy, which is exophthalmos, and pretibial myxedema. This is the classic picture for Graves' disease. So this is the findings that we're going to have. We're going to have a meaty appearance of the thyroid gland. On the iodine uptake test, it's going to be positive. It will have 60% uptake at 24 hours. Usually it should be 30% or less. Exophthalmos, which is the protrusion of the eyes, as you can see, and the pretibial myxedema. So guys, do not confuse this with the myxedema of the face. Pretibial myxedema is more common with hyperthyroidism, which is in Graves' disease. This is very important. This here, as you can see, this is a cold nodule because it's not enhancing. Cold nodule. Graves' disease, both the whole thyroid gland would be enhancing, and also the pyramidal lobe sometimes. This is a toxic multinodular goiter. We have a cold nodule and a hot nodule. Here we have hot nodule. Nothing is enhancing except one nodule over here. In the autonomous nodule, as you can see, we have a complete suppression of a gland, and then the other gland is working normally. And in thyroiditis, of course, the whole thyroid is not working because the thyroid is degenerated. This is how a goiter looks. And those are some goitrogens, which are basically stuff that can, food that can cause goiters. And they do that by affecting the peroxidase enzyme. Next is thyroid adenoma, which is basically a benign, solitary, painless nodule of the thyroid. As you can see, it's well capsulated, so there are no kind of invasions or anything. However, there could be possible hemorrhage and necrosis. This is how it looks on histopathology. Just memorize the pictures. As you can see, this is the capsule. There is no invasion anywhere, a very clear capsule with the thyroid adenoma inside. Hertel cell or oxyphil adenoma. This picture is very important. As you can see, they're large cells with granular eosinophilic cytoplasm, and the nuclei, they show atypia and pleomorphism. Just memorize this picture. It's more important. As you can see, that it's very, very pinkish due to the oxyphil production. Thyroid carcinoma. So we have multiple kinds of thyroid. I'm not sure how important these are. So the most aggressive is the papillary carcinoma, which affects the cycle from the very top. So it inhibits the RET PTC receptor over here. and the rest of the cycle. Then next we have the follicular carcinoma, which affects the RAS specifically. And then we have the anaplastic carcinoma, which completes from the follicular, and then it shares other kind of pathways. Talking about the papillary thyroid carcinoma, this is the most common type of thyroid carcinoma, and it's the most aggressive, as we said. It's typical for having the Sammour bodies. Sammour bodies are basically, as you can see, this structure is Sammour body. It's basically a kind of structure that is seen in malignant cancers. So remember, this cannot be seen in benign cancers. It's only in malignant cancer. And we have this typical appearance of the orphan Annie-eye nuclei. This appearance of the eye is called orphan Annie-eye nuclei that are found in the nuclear grooves. This is a classical findings for the papillary thyroid carcinoma. Please memorize all of these pictures. I've put this sign to tell you that this has appeared multiple times in the past questions. So just focus on those pictures that have this sign over here. Okay, so the mutation is the RET PTC, BRAF, has a poor prognosis, and the orphan Annie-eye nuclei and Sammour bodies. And something important to note is that they come with fibrovascular stock as well. This is the follicular variant of papillary carcinoma. So again, this is papillary carcinoma because it has orphan ani, as you can see in the periphery. There is orphan ani. However, it's the follicular variant. It comes as follicles. It's the normal follicular shape of the thyroid, right? So this is follicles showing the follicular variant of papillary carcinoma. Now, for the follicular thyroid carcinoma, it comes with a very thick capsule that is usually having infiltrating cells, lymphocytes. So this is the thick capsule, as you can see, and here the cells are infiltrating. This is an adenoma. It has not yet transformed to a carcinoma. The capsule is still thin and there is no invasion. Here we have carcinoma because of the thick capsule. So whenever you see a thick capsule, think about follicular thyroid carcinoma. And again, this picture was also mentioned in your slides. Next, we have medullary thyroid carcinoma. It's a very ugly looking kind of cancer. It's produced from C cells. It comes from C cells. They secrete calcitonin. This is very important. So C cells that produce calcitonin causing hypocalcemia, they are due to red point mutations. This is very important again. And on the histology, you can see some spindle polygonal cells and amyloid deposit. So it's very important to notice the green birefringence over here. Next, you have anaplastic carcinoma, and again, this picture is very important. They usually do not get a scenario, they just put you this picture, and this is anaplastic carcinoma. It's important to note that it is IHC positive. Now, done with the thyroid, let's move to the parathyroid. So this is a parathyroid adenoma, and it's the most common cause of primary hyperparathyroidism, and usually occurs in a single gland. It's encapsulated, and the proliferation are usually of uniform chief cells. So it's not ugly looking, it's very clean. The same kind of cells are proliferating. This is the carcinoma. It's more ugly looking, as you can see, and we have a fibrous capsule. There is a kind of fibrous tissue that is being produced. Diagnosis is usually capsular or vascular invasion or metastasis, not cytology. Now we have the osteitis fibrosa cystica, which basically is a complication of primary hyperthyroidism. So, primary hyperparathyroidism. So it's a bone manifestation of primary parathyroidism. So when we have osteoclasts that are breaking the bones and fibrous tissue and blood as well inside hemosiderin called the brown tumor, this is called osteitis fibrosa cystica. Okay, now moving on to the pancreas. So we know that we have three kinds of cells in the pancreas that produce hormones. We have the beta cells, which are the most common. They produce insulin. They're brown colored. And then we have the alpha cells, which produce glucagon. And then we have the S cells that produce somatostatin, and those are the least amount of cells. Type 1 diabetes occurs at 4 stages in cyto. We start with the pre-insulitis. So here you can see a normal islet, cells, normal islets. No invasion, no lymphocytes, so no clear pathology seen over here. However, the disease itself has started, but we cannot yet see it. So it's called pre-insulitis. Next, we have the peri-insulitis. This is where the lymphocytes start to accumulate around the islets. However, they're still at the periphery. They did not invade inside. So this is stage 2, peri-insulitis. Stage 3 is when the lymphocytes start to invade inside the islet cells, and here it's called intrainsular insulitis. And finally, we have the complete islet destruction, where the whole islet is destructed. Here in type 2 diabetes, we don't have the lymphocytic aggregation. Instead, we have amyloid deposition. So those amyloid deposition or hyalinization with no lymphocytes, this is usually type 2 diabetes mellitus. What are some changes that are found in diabetes mellitus? We'll start with the kidney changes, nephropathy, and diabetes mellitus. First, we have the basement membrane thickening, as you can see over here. And those guys are very important. Those 3 pictures are very important to note and to differentiate in between. First, we have the Kimmel-Style Wilson finding. So it's a weird name with a weird shape looking thingy over here. So just memorize that this picture is for Kimmel-Style Wilson. Next, we have the nodular glomerulosclerosis. As you can see, they're making kind of nodules over here, so that's easy to remember. It's called nodular glomerulosclerosis. Next, we have the diffuse mesangial sclerosis. Diffuse mesangial sclerosis. Sclerosis, from its name, there is kind of fibrous tissue. So and that's what the blue is over here. And grossly, this is how the nephrosclerosis looks like. Retinopathy in diabetes mellitus. Here we have the non-proliferative diabetic retinopathy. As you can see, the vessels are normal. However, we do have a kind of retinopathy. Next, we have the proliferative diabetic retinopathy. And how can you tell? There is a kind of tiny hemorrhages over here. They're very tiny, though, due to the capillary eruption. This is called proliferative diabetic retinopathy. Next, we have the vitreous hemorrhage. As you can see, it's a very clear kind of hemorrhage. And the cotton wool spots over here, you can see those spotting, white spotting all over the eye. And finally, we have the diffuse macular edema. Here, basically, you cannot see the optic nerve and you cannot locate the vessels clearly due to the edema. How about other complications? So we have acanthosis nigricans, which is basically the darkening of the neck area and of the armpits. We have peripheral vascular disease, which causes a decrease in the sensitivity at the foot level, causing ulcers and damage for the foot. Next, we have malignant otitis externa. We have atherosclerosis, fungal bladder infection. As you can see, the fungi over here, the branching of the fungi is clear, and oral candidiasis. Type ulceration can be of different stages. We have grade 1 ulcer, which is where only the top skin layer is ulcerated. Next, we have grade 2, which is a bit deep, but it has not reached the bones yet. Here we have Charcot arthropathy. What that is, again, basically due to the loss of the sensation at the feet level, the patients will not feel if they are injuring themselves. So we're going to have this finding called Charcot arthropathy. And here we have the necrobiosis lipoidica diabetic worm. Just memorize this picture here. It's a complication of diabetes mellitus again. This is a test that you can do again to test the sensitivity of the skin for those patients. It's called the 10G monofilament test. Next, moving on to the adrenal glands. Here we have adrenal hyperplasia, which is causing ACTH-dependent Cushing disease, or Cushing syndrome, sorry. So, and a diffuse hyperplasia, yellow lipid-rich vacuolated cells. This is the normal adrenal gland, and here it is enlarged. Primary pigmented cortical hyperplasia. As you can see here, there is kind of pigment. Also here, it's clear on the histopathology. There is kind of pigment due to the ACTH. So this is due to the hemosiderin laden from the dark cells. So the dark cells are basically made of hemosiderin laden, and vacuolated cells are lipid rich usually. This is ACTH independent Cushing syndrome. Next, we have the adrenal cortex adenoma. So we have an adenoma or a benign tumor of the adrenal cortex. And this is the carcinoma. As you can see, the adenoma is capsulated and it's good looking. Here we have the carcinoma. It's more ugly looking. It's not capsulated. So in the gross, it's a large, invasive, often very huge. And the histology, it shows atypia, necrosis, and mitosis. I'm not sure how important those pictures are. Just memorize that these are for adrenocortical carcinoma. Okay, those two pictures are for adrenocortical carcinoma. Next, we have Waterhouse-Friderichsen syndrome. So this is a kind of acute adrenal insufficiency that occurs due to bilateral adrenal hemorrhage. As you can see, I'm not sure if this is blood, but you can take it as blood just to memorize, just to relate the name with the picture. So Waterhouse-Friderichsen syndrome is basically caused by bilateral adrenal hemorrhage that is causing acute adrenal insufficiency. The picture is very important, you guys. Just memorize the picture. Next, you have autoimmune adrenalitis, which is basically a chronic adrenal insufficiency because it's autoimmune. Presentation and a primary adrenal insufficiency due to Addison's disease, histology, and a lymphocytic infiltration and cortical atrophy. So just basically lymphocytic infiltration and cortical atrophy. I don't think this picture is important. Next, we have Addison's disease, which is a cause of primary adrenal insufficiency. it basically causes autoimmune adrenal destruction. So we have a decrease in cortisol and aldosterone, and through feedback we have increased ACTH. Because of the increased ACTH, we're going to have hyperpigmentation. So hyperpigmentation is the most important over here. We have vitiligo, weight loss, fatigue, and also hypotension. Now, pheochromocytoma, it's basically a tumor of the adrenal medulla. It causes an increase in the catecholamines, basically. So what's really important about the pheochromocytoma is the rule of tens. We have the 10% bilateral, 10% extra-adrenal, 10% malignant, 10% not associated with hypertension. It can occur with Mann syndrome, and it causes, as we said, increase in plasma metanephrines and urinary VMA. Here on histopathology, we have polygonal to spindle-shaped chromaffin cells, and we have dense granules that are made of the catecholamines. It's again a kind of tumor of the medulla. I don't think those are important pictures. Just understand that it's a tumor of the adrenal medulla. Okay, so here again on the CT, it shows pheochromocytoma, and here on the MIBG scan, it is enhancing. What tests can we do? We can do the 24-hour urinary catecholamines and metanephrines, plasma catecholamines, and chromogranin A. Adrenal CT, MIBG scan, if it is metastatic, to see the metastasis. Finally, we have the Mann syndrome. We have three types. Men 1, which comes with the three Ps, Men 2A, and Men 2B. Men 1 is basically comes with pituitary adenoma, parathyroid hyperplasia, and pancreatic tumors. We're going to talk about those in a bit. Men 2A, they do not come with pituitary adenoma. They just have the parathyroid and thyroid carcinoma. So parathyroid hyperplasia, medullary thyroid carcinoma, and pheochromocytoma. Men 2B, most importantly, come with the marfanoid body habitus. So here we have glucagonoma, gastronoma for in Zollinger-Ellison syndrome, vipoma, and insulinoma. All of those are kind of pancreatic tumors that are signs of Men 1 syndrome. Here we have mucosal neuromas and marfanoid features, and as we said, those both come in Men 2B syndrome. And that's it for part 1. Next, we're going to talk about the reproductive section, patho, and clinical pictures. Okay, now, so moving on to the normal endometrial cycle, let's start with picture F over here. I'm really sorry for the picture quality. That's how it appeared on your slides. However, we have another one over here. Maybe this is clear. Let's go through this first. Let's start with the menses. So over here, you can tell that there is kind of shedding. The tissue is not attached to the tissue behind it. So this is menses. And then we're going to start the cycle all over. We'll start with the proliferative phase. So in the proliferative endometrium, we have kind of glands that are growing. So we have tortuosity of the glands, and this occurs from day 1 till day 14. And then we have the subnuclear or the basal vacuolation. What happens here is that those glands that have grown in the proliferative phase is now having the secretions inside them. So they're going to push the nuclei to the periphery, and the vacuoles will be full with the secretions. In the secretory phase, those secretions are going to be secreted, so no more of those long nuclei. Instead, there is more secretion in the lumen, and that would be clear in the next pictures. And then this is the pre-decidual phase, and this is the neutrophilic phase. Just memorize the pictures as they are. So again, this is the proliferative phase, there are glands and mitosis. Next in B, we have the subnuclear vacuolation. Here the vacuoles again push the nucleus upward. And then in letter C, we have the secretory phase. As you can see, the secretions are moving into the lumen. And finally, we have the menses over here, the menstrual cycle. As you can see, there is blood. Type endometriosis. What is endometriosis? It's basically when there is ectopic endometrial tissue outside of the whole uterus. So sometimes you can find it in the ovaries, in the colon, in multiple different parts of the body. And endometriosis mainly comes in a triad. So we have dysmenorrhea, infertility, and I forgot the triad. What was the third thing? I'm not sure. Anyways, it comes with cyclic pelvic pain, dysmenorrhea, pain on defecation, infertility, and bowel symptoms as well. Here we have an endometrioid tissue cyst. It can sometimes come in a cyst or in a tissue. And if it became hemorrhagic, we will have this chocolate cyst appearance, as you can see over here. Same thing in the pathology. You can see that there is kind of hemorrhage. This is endometriosis in the colon. This picture is very important. It appeared in the pus. Next, we have adenomyosis, which is basically when the endometrial tissue is within the myometrium. Type. Let's just review the layers of the uterus. Here, inside, we start inside, okay? This layer, at the very inside, which looks very pink, this is the endometrium. Here we have the myometrium. And finally, here we have the serosal layer. Hello? So when we have the endometrial tissue in the myometrium, this is called adenomyosis. Here we have an endometrial polyp. So basically, it's a polyp that grows in the endometrium. It is associated with tamoxifen use and this gene over here. Next, we have Bartholin cyst, which is basically a kind of cyst or abscess that occurs at the Bartholin glands. This causes a kind of severe pain and discomfort and is usually cured by surgical removal, and it's not malignant. Next, we have lichen sclerosis. So let's just keep in mind that we have lichen sclerosis and lichen simplex chronicus, just to differentiate between both. In lichen sclerosis, this happens mainly in post-menopausal women. We have thinning of the epidermis and the loss of Reitz pegs. This increases the risk of squamous cell carcinoma. However, in lichen simplex chronicus, here we have squamous cell hyperplasia. So we have epithelial hyperplasia causing acanthosis and hyperkeratosis, and this is not has no increased risk of malignancy. This is known for causing pruritus. So if they put in the question that the patient is having pruritus, you should think lichen simplex chronicus or squamous cell hyperplasia. No pruritus, increased risk of squamous cell epithelium, carcinoma. So this is lichen sclerosis, and this picture is important. This is lichen cell sclerosis. Next, we have condyloma acuminatum, and this basically occurs from HPV type 6 and 11. It's a sexually transmitted disease that causes condyloma. As you can see over here, it looks like the warts. And this is how it looks on histology. We have the perinuclear halo. So whenever you see perinuclear halo and coilocytic changes, which are basically the atypia of the cells, cytoplasmic and nuclear atypia of the cells due to the viral infection, always think HPV. Here we have the perinuclear halo. Here we have the proliferation of the squamous cell epithelium. This is called condyloma acuminatum. Next, we have the classic vulvar intraepithelial neoplasia. So I don't think those pictures are really important. I've just put them for the sake of completion. Let's just go through them real quick. So here we have, it's a kind of, we have two types. We have the low grade and the high grade. In the low grade, it's literally normal skin. There is no invasion. In the high grade, it can cause carcinoma in situ, nuclear abnormalities. We have an intact basement membrane. We have coilocytic changes, again, due to HPV dependency, and it can evolve into basiloid or warty carcinoma. So this is the warty carcinoma, and this is the warty carcinoma over here. This is the warty carcinoma, and this is the basiloid carcinoma. So from its name, basiloid, it's colored blue as well, okay? It has nests and cords. Both of them show the coilocytic atypia, and these are seen in warty and basiloid squamous cell carcinoma, HPV-related vulvar intraepithelial neoplasia. Here we have the differentiated vulvar intraepithelial neoplasia. This is not HPV related. As you can see, there is no coilocytic changes like was seen in the previous pictures. Here we have keratinizing squamous cell carcinoma. I think you guys by now have memorized this cancer. As you can see, we have the keratin pearls, the increased thickness of the epithelium. And this is also linked to lichen sclerosis. If you guys remember, we said lichen sclerosis, it increases the risk of squamous cell carcinoma. Next, we have papillary hydroadenoma. Just memorize the picture, nothing more is needed. So this is papillary hydroadenoma. It occurs at the superficial vulva, and it's related to glands with papillary projections. Next, we have extramammary Paget's disease. So it's basically a growing malignant skin condition where the Paget cells, which are the adenocarcinoma cells, spread within the epidermis. I want you guys to memorize these three pictures and to know that this picture is positive for the Alcian blue and this picture is positive for cytokeratin. Just memorize these three pictures and link them to extramammary Paget's disease. Next, we have melanoma, which is basically a cancer of the skin, right? So we have the melanocytes differentiating a lot. You can tell from the dark color over here and same over here, okay? And this is how it looks grossly. It's important to note that the IHC markers are positive for S100 and HMB45, and it's negative for cytokeratin. Next, we have vaginal adenosis. So basically, this occurs due to in utero DES exposure. It's very important to relate the DES exposure to vaginal adenosis. Those are the basic pictures, and it's mainly a benign condition. However, it can transform into clear cell carcinoma. This picture is very important. Clear cell carcinoma. You can tell that the cells are kind of clear. They're not full of anything. You can relate that to the name. So clear cell carcinoma, it can occur due to vaginal adenosis and again, especially with the history of DES exposure. This picture again is important. This is embryonal rhabdomyosarcoma. This is known for the grape-like clusters, exactly. So grape-like clusters, as you can see over here, is a common feature for embryonal rhabdomyosarcoma. It's also called sarcoma botryoides. On the pathology here, on this slide, you can see here the tennis racket. So tennis racket in the cambium layer. The tennis racket in the cambium layer is again a special feature for embryonal rhabdomyosarcoma. Okay, now we're moving on to the cervix. As you know, we have the junctional, the junction at the cervix. We have the squamo-columnar junction. This is the area where the endocervix with the columnar epithelium changes into ectocervix with the squamous epithelium. And this is a common site for atypia, dysplasia, and carcinoma. A cervical polyp is a small pedunculated benign mass that grows at the cervix, as you can see over here and here as well. Overgrowth of benign stroma with columnar or squamous epithelium. So it depends at the site, and it's usually benign. Now we're going to talk about common infections. These were not in your microbiology lectures. We will mention the bacteria and stuff from your micro at the very end. Okay, so these are from your clinical and patho lectures. Candidiasis, which is a common infection. They appear as white, patchy mucosal lesions with thick, curdy white discharge and vulvovaginal urethritis. As you can see over here, you can tell the branching of the candida. Next, we have trichomoniasis. This is how it looks. Trichomanus vaginalis. It's a kind of parasite, flagellated protozoa. Green, yellow, frothy, foul discharge. So whenever you see a female with green, yellow, frothy, foul discharge, think trichomoniasis. Next, we have the herpes simplex virus, HSV. It mainly causes cervicitis. HSV type 2 is the one that is sexually transmitted. And clinically, we're going to see vesicles and ulcers on the cervix, vagina, vulva, urethra, and perianal skin. We're going to talk about this more in the microbiology lectures. Coilocytotic atypia. This is what we have talked about before. This is this basically refers to the changes that occur to the cytoplasm and to the nuclei of the cells that have been infected by HPV viruses. Not HPV, but any kind of virus, okay? So you can see that the cells have changed. The nuclei are changing. We have a perinuclear halo as well. Again, those show HPV infection. Coilocytic atypia is divided into 3 grades. We have grade 1, which occurs at the lower 1/3, grade 2, the lower 2/3, and grade 3, which involves the full epithelium. And this picture shows the cervical cancer progression. It's not that important, you can just go through it. Now, for cervical carcinoma, the invasive type. So we have microinvasion into the basement membrane. So whenever the basement membrane is no more intact and we have invasion, this is considered invasive cervical carcinoma. And here we can have sometimes squamous cell carcinoma. So it could be with transitional epithelium or squamous epithelium. Here we have the squamous cell variant. You can tell from the keratin pearls. And this is how it looks grossly. As you can see, this is the cervix, and this is the cancer. Next, we have the staging. So we have 0, carcinoma in situ. You cannot see it grossly. Next, we have stage 1, which is confined to the cervix. Next, stage 2, we have extension beyond the cervix, but without extension to the lower third of the vagina or the pelvic wall. So it extended from the cervix, but not to the lower third. And then we have stage 3, which has reached the lower third of the vagina. And finally, stage 4, it has metastasized. Next, we have endometrial hyperplasia, which is basically the thickening of the endometrial lining, which is also a case that predisposes women into endometrial cancer. So it's a pre-malignant stage. And this is a kind of advanced endometrial hyperplasia. It's usually not this advanced. Okay, so we have endometrial hyperplasia without atypia and with atypia. Without atypia, as you can see over here, they're just kind of crowded glands. They're cystic, irregular glands, proliferative-like. However, there is just a kind of thickening, and we're going to go through the radiology lectures. We'll see how it's a limited kind of thickening. It has a low risk progression to adenocarcinoma. Next, we have the atypical hyperplasia. Here we have more, the glands are more crowded and minimal stroma. Here there is more stroma, as you can tell. Here there is no more stroma. It's very minimal. And we have large around mitotic glands. This is a pre-malignant condition. These pictures are important. This picture is important, you guys. So this is atypical hyperplasia, endometriosis. Endometrial hyperplasia. Atypical endometrial hyperplasia. Here we have endometrial polyp. So again, it's a benign asymptomatic polyp that grows in the endometrium. It can cause abnormal bleeding, but it usually is just a benign polyp. Next is endometrial adenocarcinoma. This is the most common gynecological malignancy and the leading cause of postmenopausal bleeding. Always in a postmenopausal woman, if there is bleeding, you need to rule out endometrial adenocarcinoma. We have two types. We have the endometrioid type, which makes up 80% of the cases. Those are related to PTEN mutations, endometrial hyperplasia, null parity, and tamoxifen. Tamoxifen is basically a drug, you guys should know by now. It's basically a drug that is given for breast cancer. However, it increases the risk of endometrial cancer. Type 2 is the serous type, and this is unrelated to estrogen, and it occurs at the older age. This is how it looks, and here is how it looks on histopathology. So again, the glands are very crowded. It's a kind of tumor in the endometrium. Just memorize those pictures. But now for the staging, again, stage 1 is confined to the corpus uteri. Stage 2 involves the corpus and the cervix, and stage 3 extends outside the cervix, but within the true pelvis. Stage 4 extends from the true pelvis and can sometimes invade the bladder or the rectum. Again, staging is the most important factor for prognosis. Leiomyoma or fibroid is basically the most common neoplasm in the female genital tract, and it's estrogen responsive. This is very important. It's important to note that fibroids, they respond to estrogen. This means that they can grow and shrink during the cycle. So in postmenopausal women, we expect the fibroids to be shrinking because of the reduction in estrogen. Mutation MED12 is the most important mutation. As you can see, it's leiomyoma, so they're made up of smooth muscle cells, so spindle cells with fascicular arrangement. As you can see, the spindle cells over here are very clear. So again, this is leiomyoma or uterine fibroid. Even here, as you can tell, it's a very smooth-looking tumor. The leiomyosarcoma, this is it's more fleshy and bulky, and it has more atypia. As you can see, there is more mitosis, and the cells are more atypical. Again, the mutation is in MED12. Next, we have the choriocarcinoma. A choriocarcinoma is basically choriocarcinoma is a highly aggressive kind of tumor that is known for having an increase in beta HCG, and it occurs due to hematogenous spread. It's very important to note that choriocarcinoma happens after a complete mole or partial mole. So it happens after a kind of abnormal pregnancy, either complete mole, partial mole, abortion, ectopic, or normal pregnancy sometimes. And it's important to note that there is no fetal part or villi. This is the diagnostic criteria. This is the picture of choriocarcinoma. You can link it to the snowstorm appearance of the complete mole, of the partial mole, sorry. It's kind of have this hectic appearance. Next, we have the follicular cyst. Follicular cyst is very important. As you can tell, this is the classical picture that it has, and it's made of granulosa cells. So these are the granulosa cells, and those are characteristic for the follicular cyst. Next, we have the corpus luteum cyst, and again, these pictures are very important. What's important to note is that in the corpus luteum cyst, we have a line of a bright yellow rim around the cyst. So the cyst is lined by a bright yellow tissue containing luteinized granulosa cells. Those may rupture and cause peritoneal reaction. We're going to talk about the peritoneal reaction in a bit. Next, we have polycystic ovarian disease, where basically we have multiple cysts or follicles that surround the ovaries. And the common causes are anovulation, which are basically a cycle where no ovulation occurs, infertility, obesity, hirsutism, and oligomenorrhea. Next, we have the benign serous cystoadenoma. So this is benign and it's serous. As you can see, the cyst is filled with fluid, however, it is serous. And this is how it looks on the macroscopically. So small papilla, single layer of tall, ciliated columnar epithelium. Nuclei is parallel to the basement membrane. This is borderline serous tumor. Here we have the epithelial lining lacking stromal invasion. Again, so it's borderline because there is no stromal invasion. However, it's worse than the serous cystoadenoma, so it's not benign. Here we have KRAS and BRAF mutation with only rare mutations in the P53. Next, we have the papillary serous cystoadenocarcinoma. Here, this is a kind of malignant ovarian tumor, and this is the most common malignant ovarian tumor. So the most common malignant ovarian tumor is the papillary serous cystoadenocarcinoma. Risk factors are null parity, family history. BRCA is very important. So the papillary serous cystoadenocarcinoma has two types. You have the low grade, KRAS or BRAF, and the high grade, which is due to the P53 mutation. And again, this can spread to the peritoneum. As you can see here on the picture, it has Sammour bodies. So the papillary serous cystoadenocarcinoma has Sammour bodies, same as papillary thyroid carcinoma, if you guys can remember. And we have invasion into the stroma in this picture. And this is how it looks grossly. Now, this is from your radiology lecture. The doctor put this picture aside and it did not seem like an important picture. It was very small. I've just added it for the sake of completion. So this is how papillary serous cystoadenocarcinoma appears. And as we said, it predisposes patients to ascites, and it can cause the abdomen to be really big. So this is ascites-related papillary serous cystoadenocarcinoma. Next, we have the benign mucinous ovarian tumor. Here, as you can tell, the nuclei are compressed by the mucin. So we have elongated cells, columnar epithelium, that have the nuclei compressed by the mucin. This is the papillary mucinous cystoadenocarcinoma. Risk factors are smoking and KRAS mutation. Again, you can see the nuclei, the columnar epithelium, and the nuclei that are pushed. However, here you can tell that there is more atypia, there is more mitosis. Okay, so this is how the ovarian cystoadenocarcinoma looks grossly, and this picture was also added by your doctor. Next, we have pseudomyxoma peritoni. Those pictures are very important. Pseudomyxoma peritoni. So this is basically mucinous ascites from the appendiceal tumors or ovarian tumors. So this occurs due to the spread of metastasis. It's basically metastasis, and it causes omental caking. It can cause severe complications like intestinal obstruction and death. So this is called pseudomyxoma peritoni. Next, we have endometrioid carcinoma. Mutations are PTEN, KRAS, beta-catenin, and microsatellite instability, and P53. This is how it looks on the histopathology, endometrioid carcinoma. So we have the normal endometrial glands. However, we have increased growth, making an endometrioid carcinoma. And as you can tell over here, it could be glandular or it could be mixed. So cystic or solid. It could be cystic or solid. And this is a cystoadenofibroma, which is basically made of fibrous tissue. It looks white, firm, ovary due to the fibrosis, and it's made of simple columnar epithelium. Next, we have Brenner tumor. Again, this tumor is very important to you guys. As you can see in the histopathology, the epithelium is transitional epithelium. So adenofibroma with transitional type epithelial cells that resemble the bladder epithelium. We have nests of urothelial-like epithelium within dense fibrous stroma. Next, we have the teratoma. So we have two types of teratoma. We have the mature teratoma and the immature teratoma. The mature teratoma is the most common benign germ cell tumor, and it usually has multiple, it contains different components. It could be due to 2 or 3 embryological layers. So for the histology, interestingly, sometimes we can have struma ovari. So what's that? Sometimes the teratoma on the ovaries can have thyroid hormone producing cells, which is called struma ovari. Those are going to produce thyroglobulin and TTF positive. And the patient is going to show positive hyperthyroidism signs. However, sometimes you can also have carcinoid features. So the salt and pepper appearance. As you can see here, it looks like a thyroid, the thyroid follicles. Here it looks like the carcinoid features, salt and pepper chromatin, and also it produces the hormones of carcinoid tumors. The immature teratoma is basically, depending again on the components, it's solid with necrosis, it's hemorrhagic, sometimes have hair, cartilage, and bone. Grading 1 to 3 is based on the percentage of the neuroepithelium. So the immature teratoma is made more of the neuroepithelium, and that's how grading, and that's how you grade teratoma, depending on the neuroepithelium. Next, you have the dysgerminoma, and this is very important. The picture is very important to you guys. So what's most important is that this is the most common malignant germ cell tumor. So, and this is the female counterpart of seminoma. So in females, it's called dysgerminoma, and males, it's called seminoma. And it's usually unilateral. What's most important is that in this tumor, we have increased LDH. So whenever you see in a question, increased LDH, plus this picture mainly, this picture is very important, but this is dysgerminoma, sorry, okay? And it's important to note that it has large clear cells, central nuclei, and fibrostroma with lymphocytes. Next, we have endodermal sinus tumor, or the yolk sac tumor. Now, yolk sac tumor is very important. This picture is very, very important. It has the Schiller-Duval body, and this shows a lace-like structure. That's what the picture is called, lace-like structure. And here we have the Schiller-Duval body. Again, those are signs of yolk sac tumor. This is a kind of germ cell tumor again, but it's not the most common. It's the second most common. So the most common germ cell tumor is the dysgerminoma. The second most common is the yolk sac tumor, which has the Schiller-Duval bodies and the lace-like structure. Markers, it's positive for AFP, Schiller-Duval, and Schiller-Duval bodies, which are diagnostic. Next, we have the choriocarcinoma. This is the picture of choriocarcinoma. Small hemorrhagic tumor with early hematogenous spread. Markers are increased beta HCG. So the increased beta HCG is very important in choriocarcinoma. Again, this occurs mainly due to partial or complete modes. I think we talked about this before. I should have merged the slides. My bad. So again, this is a picture of choriocarcinoma. It occurs after complete or partial molar pregnancies, most probably. And it makes sense that the markers are increased beta HCG, right? Next, we have the granulosa cell tumor, and this picture again is very important. Granulosa cell tumor, they have bodies called the Cole-Exner bodies. So the Cole-Exner bodies, or the coffee bean nuclei over here, are characteristic for the granulosa cell tumor. And what's most important about this tumor is that it produces increased estrogen. So it causes increased estrogen, causing precocious puberty in young female and endometrial hyperplasia or carcinoma in adults. What is it made from? It's made from granulosa cells and theca cells. This picture is very important to you guys. Granulosa cell tumor. Next, we have the sertoli-Leydig cell tumor. Sertoli-Leydig cell tumor, again, this picture is very important. What's important to note that in this tumor, we have increased androgens. So in granulosa cell tumor, we have increased estrogen. In sertoli-Leydig cell tumor, we have increased androgens. Next, we have the fibrothecomas, and those are known for having the plump spindle cells, again, that produce increased estrogen. So it's a kind of fibroma. So we have fibroblast, collagen, firm white mass. This is called a fibrothecoma. And because it's a thecoma, again, it has increased estrogen. Next, we have Krukenberg tumor. So this is a metastatic ovarian tumor, usually from the GI, commonly the stomach, and they're made up of mucin-filled signet ring cells. This is how they look on histopathology. Just memorize the shape of the pictures. So this is Krukenberg tumor. So I know the ovarian tumor lecture is very dense and they're actually really confusing. Like even the pictures, there's nothing much to differentiate between. So I've put this kind of summary for you guys. I thought maybe it would help. Just the main or the keywords that would help you answer the questions or the scenarios. Like here, Sammour body, CA125, this is serous carcinoma. If you see CEA, this is mucinous carcinoma. The signet ring cells, this is Krukenberg tumor. Sertoli-Leydig, they have increased androgens causing virilization. The granulosa cell tumor, they have increased estrogen. Thecoma has spindle cells. Here, these are very important, you guys. The dysgermanioma, they have increased LDH. The old sac tumor, they have increased AFP, and this is very important. Choriocarcinoma, they have increased beta HCG. I thought it would be a good summary for you. Just go through them real quick. And I promise ovarian tumor lectures questions are way easier than studying the lectures themselves. Okay, inshallah. Now let's start with the breast pathologies. Okay, starting off with the duct ectasia, which is basically a pathology in the breast that is seen in older multiparous women of 50 years. So here we basically have distension of the subareolar ducts as a result of chronic inflammation. So you have chronic inflammation of the subareolar ducts that is causing duct ectasia, and they're present at the periareolar mass. Please memorize this picture, it's very important. This is duct ectasia. Next, we have fat necrosis. The pictures are very typical for fat necrosis. As you can see, the white round structures tell you that those are adipocytes. So it's the most important thing about fat necrosis is the history of trauma or surgery. So we have foamy macrophages, giant cells that progress to fibrosis and calcification. So it's important to note that fat necrosis can change into calcification. Next, for the cysts, we have benign fibrocystic changes. Here we have a cyst with apocrine and apocrine metaplasia and calcification in the middle. However, it's benign. So this is a benign fibrocystic change. Picture is not that important. Just take a look at it. Next, we have epithelial hyperplasia. So normally the epithelium, the ductal epithelium is of 2 layers. If it was more than 2 layers, like here, those are a lot of layers. So this is epithelial hyperplasia, and this increases the chance of breast cancer. Next, we have sclerosing adenosis. I just want you to memorize this picture. So this is sclerosing adenosis. Next, we have complex sclerosing lesion. Now, in the complex sclerosing lesion, we have a central stellate or radial scar, and you can tell from this picture because the fibrous tissue is all collecting in the middle, causing a central stellate or radial scar. So this is similar to sclerosing adenosis, but this is larger. So again, here we have kind of fibrous tissue. We don't have a central scar. Here we do have a central scar, and it presents as an irregular mammographic density. Next, we have the papilloma, which is basically a benign papillary tumor from the ductal epithelium. We have 2 types, the central or the solitary, and the peripheral, which is made up of small ducts and is usually deeper. It presents with bloody discharge and can cause a possible subareolar mass. Next, we have gynecomastia. Here we have subareolar enlargement. I cannot emphasize more on this word. Subareolar enlargement is seen in gynecomastia, and this is how it looks like. Next, most importantly, we have the ductal carcinoma in situ. So ductal carcinoma is very important. Guys, please memorize those pictures. I want you to memorize all of those pictures. So this is the comedo type. As you can see, there's a kind of comedone in the middle of the gland. Okay, so this is ductal carcinoma in situ comedo. This is the micropapillary. They look like papillary structures, and this is the cribriform. Okay, and in ductal carcinoma in situ, there is a high risk of progression to invasive carcinoma and high risk of recurrence. And of course, there is kind of calcifications and increased density. Next, we have Paget's disease of the breast. So we talked about the extramammary Paget's disease. Now we're going to talk about the one of the breast. We have malignant glandular cells in the nipple or the areola epidermis, and this is how it looks like. It's red, scaly, or eczematous lesion, and this is how it looks like in the histopathology. It's also associated with the underlying ductal carcinoma in situ. Next, you have lobular carcinoma in situ, which is a more benign kind of carcinoma. It's a non-invasive proliferation in ducts and lobules in both breasts. We have this occurs due to loss of E-cadherin, and there are no microcalcifications. So it's important to note that in the ductal carcinoma there is calcifications. In the lobular there is no calcifications, and those look more of lobules. That's how you can memorize this picture. This is the invasive ductal carcinoma. So here خلاص it's transformed into invasive ductal carcinoma. This is the most common breast cancer, and this is the most severe or the most malignant kind of breast cancer. Okay, so it causes skin dimpling or nipple retraction. As you can see over here, there is a huge scar that is causing nipple retraction and skin dimpling, and this is how it looks in the histopathology. Duct-like structures in desmoplastic stroma. So we have desmoplastic stroma that has duct-like structures in between. Next, we have the invasive lobular carcinoma. Here they have this Indian file pattern. So Indian file pattern, a kind of appearance, is found in invasive lobular carcinoma. Here we have no papilla, dense fibrosis, and it has a bad prognosis. Next, we have the medullary carcinoma. Please memorize this picture, you guys. This is medullary carcinoma of the breast. Here, it's well circumscribed, soft, fleshy mass. What's most important to note here is that this tumor is triple negative. So estrogen negative, progesterone negative, and HER2 negative. So this is it does not respond to hormonal therapy. Next, you have the mucinous or the colloid carcinoma. This usually occurs in older women. It's slow growing and well circumscribed. It's usually a benign tumor. So it's a mucin or colloid carcinoma. Next, we have the tubular carcinoma. This is a small, well-differentiated breast cancer with good prognosis. It's rarely palpable. It's seen as irregular densities on mammography. This is tubular carcinoma. Next, we have the fibroadenoma. As you can see, it's rubbery inconsistency. So rubbery inconsistency moves freely. This is called fibroadenoma, and this is the most common benign tumor of the female breast females that are less than 30 years, and usually it's treated by lumpectomy. Next, we have the Phyllodes tumor. This is a very important picture. This picture is Phyllodes tumor. It's basically a stromal tumor, leaf-like pattern. It causes a palpable mass. It is low grade, local recurrence. If it was low grade, it causes local recurrence. However, high grade can cause rare metastasis. And that's it, finally, for the pathology of the reproductive system. I know it's a lot. I promise the pictures that come in the exam are way easier. At least for the ovaries, the breasts are kind of confusing. But inshallah khair, inshallah you guys are going to do well in those. Now let's move on. We're done with the hard part. Let's start with the pregnancy. So here we have an ascending infection of the placenta. So we have two types. We have either acute chorioamnionitis, which is basically neutrophilic infiltration of the fetal membrane, either the amnion and the chorion, and we have the phenicitis, which is basically neutrophilic infiltration of the umbilical cord. The amniotic fluid becomes cloudy with purulent exudate neutrophils. So this is the placenta over here. And this is the histopathology. I don't know what they're showing you exactly. I don't think it's important. Just know the ascending infection of the placenta. Next, you have the hematogenous infection of the placenta, which is basically infection through blood, either through placental vellitis, where neutrophils and lymphocytes infiltrating placental villi and membrane, and or due to torch infections. We have the toxoplasmosis, the syphilis, TB, listeriosis, rubella, and CMV and HSV. They cause hematogenous infection of the placenta. Here we're going to talk about spontaneous abortion or miscarriages. Diagnosis is usually done through ultrasound, microscopic examination. Usually we have the presence of chorionic villi confirms the spontaneous abortion. So the decidua alone is not sufficient. You need to see the chorionic villi over here and the decidual cells. What are some causes of the abortions or the miscarriages? It's an abnormal uterus. We have a septate uterus, sometimes a uterus of, in some syndromes, it has adhesions and cannot bear to be pregnant. And sometimes we have the bicornate uterus. All of these kind of uteri can increase the risk of abortions and miscarriages. طيب multiple gestations. What do we mean by multiple gestations? We basically mean that يعني multiple pregnancies. So a patient is pregnant with 2, 3 or more babies. So here we have dichorionic, diamniotic pregnancy, where we have 2 placentas and 2 sacs. Here we have dichorionic, diamniotic, but fused placenta. So 2 placentas or 2 sacs, however, the placenta is fused. Important thing to note, if for you guys not to يعني get confused, a chorion is a placenta, okay? والamnion is the sac. Here we have monochorion, so 1 placenta, and diamnion, so we have 2 sacs. Here we have conjoined twins, so monochorionic and monoamnionic sac. طيب, complete hydatiform mole. So sometimes you have a kind of pregnancy that is called a molar pregnancy, which has a lot of يعني, abnormalities. It could be, let's start with the complete hydatiform. It occurs with a 46XX or 46XY. So we have normal chromosomal distribution. All villi are hydropic, marked trophoblastic proliferation, absent fetal tissue. So in complete hydatiform, we have absent fetal tissue and grape-like structures if we did the evacuation. So how do we treat complete hydatiform mole? We do evacuation. So we empty the uterus from what was inside it. And we can see that it looks like a grape-like structure. طيب, هلا on ultrasound, before we do this evacuation, we're going to see a snowstorm appearance. So whenever you hear a snowstorm appearance, grape-like structure, this is a complete hydatiform mole. Now, something important is that it can progress to choriocarcinoma. If you guys remember, we talked about choriocarcinoma. We said that it's related to hydatiform mole and that we're going to have elevated HCG. So this is how it looks. These are the snowstorm appearance, and these are the vesicles or the grape-like structures. طيب, now what are some important tests that are done in pregnancy? In the first trimester, we do an ultrasound that measures the knuckle translucency. Increased knuckle translucency at the 11th to 14 weeks suggests higher risk of chromosomal abnormalities like Down syndrome. Knuckle translucency over here. طيب guys, those pictures are from your clinical lectures. We're going to talk in depth in the radiology section about all of these kind of tests. This is just a quick, just to make it complete, يعني, to ensure that I included everything from the clinical lectures. طيب, now miscarriage. We have different types of miscarriages. This is a threatened miscarriage. What do you mean by threatened miscarriage? In a threatened miscarriage, we have a kind of vaginal bleeding, cramping. However, the cervix is closed. On ultrasound, there is a live intrauterine pregnancy. So this is just a threatened miscarriage. Next, we have an incomplete miscarriage where we have vaginal bleeding, cramping, and an open cervix. So the cervix is open, meaning that some parts of the pregnancy is lost. However, on ultrasound, we have retained products of the conception. Finally, we have complete miscarriage. Here we have bleeding, cramping, tissue passage, and a closed cervix. So a closed cervix, because all of the structures are خلاص يعني no more in the uterus, and on ultrasound, there are no more retained products. طيب, an important thing to note is to have a good pregnancy, we need to have a gestational sac. So you need to see a gestational sac in order to say that this woman is pregnant. This is how gestational sac should look like. And sometimes it looks like a pseudo sac. This pseudo sac is not good for pregnancy. It's an irregular, bleeding, ectopic, urgent, so it means there's something wrong. This is not a usual pregnancy. Next, you have subchorionic hematoma, which is basically a kind of bleeding that occurs behind or like below the chorion, which is the placenta. So accumulation of blood within the folds of the chorion next to the placenta or behind the placenta. Here we have placenta previa. Placenta previa is basically when the placental implantation is not implanted right. So placenta should ideally be implanted in the top corner of the uterus. If it was implanted below that, so over here, it's implanted at the edge, but it's not covering the cervix. Here it's called marginal placental previa. If it was completely covering the cervical um, the cervix over here, it's called a complete placenta previa. Vasa previa is basically when the fetal vessels cross the cervix. So here we have placenta previa, the placenta crosses the cervix. Here the fetal blood vessels cross the cervix, and this causes risk of fetal bleeding if ruptured. That's it for the placental, for the pictures related to pregnancy from your clinical lectures. Now let's talk about microbiology. طيب. Starting off with an easy virus, HSV, which causes genital herpes. This is how it looks. It causes kind of vesicles, painful vesicles and painful ulcers on the genital area. Okay, so it's basically an enveloped linear double-stranded DNA that causes vesicles, as we said, and painful ulcers. How do we test for that? We do the NAAT PCR, which is the most sensitive test. And we can do the Zank smear, as you can see over here, the Zank smear. It's not specific, however, it can show multinucleated giant cells with eosinophilic internuclear inclusions. Next, we have syphilis, which is caused by T. pallidum. This is very important. Syphilis can cause three types of syphilis. We have the primary syphilis, secondary syphilis, and tertiary syphilis. So the primary syphilis is basically just ulcers in the genital area or even at the mucosal areas in the body. Next, we have the secondary, where those ulcers can change into condyloma lata. So it's important to note that condyloma lata is different from condyloma of the HPV, right? So condyloma lata is found in syphilis, and it can change into tertiary, which causes severe bad changes in the body. Late. Okay, yeah, that's it for this. This is how it appears on dark field microscopy. So we have the spirochetes over here. So they are kind of spirochetes that appear in the dark field microscopy. How do we diagnose them? We do the NTT screening for screening and for monitoring. We can do the RPR, the VDRL, which is used in CSF samples in neurosyphilis. Next, we have the Haemophilus ducreyi, which is known for the railroad track, as you can see over here. It causes the chancroid disease. So those are fastidious gram-negative Coccobacillus, oxidase positive, and catalase negative bacteria. It causes painful ulcers. Again, so in those ulcers, it's important to note what's painful and what's painless. So till now, we said that Haemophilus ducreyi and HSV causes painful ulcers. However, the syphilis causes painless ulcers. Okay? So it causes painful, non-indurated, dragged edges ulcers that cause also tender inguinal lymph nodes. Next, we have granuloma inguinale donovanosis, which is caused by the Klebsiella granulomatis. Klebsiella is an intracellular gram-negative bacilli. Again, this is painless and a slowly progressive ulcer. It causes beefy red friable base. So whenever you see a beefy red or friable base lesion, think about Klebsiella granulomatis causing granuloma inguinale donovanosis. It causes Donovan bodies from its name, it causes or it appears as Donovan bodies, which are basically used for diagnosis. Next, we have lymphogranuloma venerum, which are caused by Chlamydia trachomatis L1 to L3. So it's important to note Chlamydia trachomatis L1 to L3 because we have another subtype. Those cause lymphogranuloma venerum, and this is how it looks. This is the groove sign. Again, those cause painful inguinal lesions, as you can see over here. So they're small, painless ulcers, but they can cause at the inguinal area painful lesions, showing the groove sign. This is just a quick summary for you guys to review those pathogens. Sorry, those يعني, agents. Now for your second microbiological lecture, we have Neisseria gonorrhea. Neisseria gonorrhea is an intracellular gram-negative diplococcus. It attaches to the columnar epithelium at the urethra or the cervix and enhances the transcytosis. This is how it looks. So if a baby was born when the mother is infected with Neisseria gonorrhea, this is how he's going to appear. This is called ophthalmia neonatal. Okay, this is normal and this is the abnormal. You can see the discharge due to the infection of Neisseria. Again, this is the typical specimen that is used for Neisseria, chocolate medium overgrowth, Fair Martin medium for Neisseria only. And of course, we have the giant cells that have multiple cells inside. This is non-gonococcal urethritis, and this is important to note. So non-gonococcal urethritis, this produces clear and serous discharge, unlike this, which is a purulent discharge. Next, we have chlamydia trachomatis. This is DK. So the chlamydia trachomatis, that is DK, it causes cervicitis, and patients usually present with pelvic inflammatory disease, infertility, discharge. But again, in newborn, it causes inclusion conjunctivitis, so same as Neisseria gonorrhea. It also appears in reactive arthritis, so in Reiter's disease, where we have arthritis, conjunctivitis, and urethritis. Here, the NAAT test is again the most sensitive. So this is how it appears. This is chlamydia. Okay, and it could be iodine stained to show the inclusion bodies in the McCoy cells. So inclusion bodies in McCoy cells is very important in chlamydia trachomatis disease. Next, we have trichomoniasis, which is called by Trichomonas vaginalis. What's really important to note here is the frothy green discharge, dyspareunia, and the strawberry cervix. Okay, and here we have the motile trichomonads seen in the wet mount, which is diagnostic motion. So this is used to diagnose the trichomoniasis. Next, we have bacterial vaginosis. Bacterial vaginosis is what's most important about this is the clue cell. So it's important to note that clue cell that is shown in this picture and this picture are very characteristic for bacterial vaginosis. How do patients appear? They come complaining of a fishy odor that is worse after intercourse and menses, and thin white gray discharge, okay, plus itching. Next, we have the vulvovaginal candidiasis. Of course, it appears as white, thick, curd-like appearance, and it's white, of course. Risk factor is antibiotics. Next, we have the skin warts, which is the common warts, which comes from HPV types 1, 2, and 4 mainly, unlike the genital warts that come from HPV type 6 and 11, as you can see over here. Those are called condyloma acuminata. So condyloma acuminata for HPV and condyloma lata for the where was the condyloma lata? I forgot. Okay, here, condyloma lata for syphilis. So condyloma lata in syphilis and condyloma acuminata in HPV. Okay, and of course, if you guys remember, we talked about this before. In biopsy, we're going to have atypical coilocytosis. And this is the anogenital warts called Buschke-Lowenstein tumor. Just note this picture and know that this is Buschke-Lowenstein tumor. Finally, we're going to go through the radiology. Inshallah, radiology will be really easy. It's just a kind of review of everything we have went through. So unfortunately, the doctor that gave you the last two lectures has changed. So I tried to include everything that he has included in his lectures. Inshallah, he brings like their pictures for you guys. Okay, starting off with the parathyroid adenoma. So as you can see here, we made this uptake test. 15 minutes after the tracer administration, we have a a clear uptake in the parathyroid gland, right? After 3 hours, they washed out. This means that this is negative, so no detectable parathyroid adenoma. However, here it stayed positive after 3 hours, showing that there is a parathyroid adenoma on the lower right parathyroid gland. Ectopic parathyroid gland, again, we do the uptake test. However, here we see that the uptake is inferior to the thyroid pole, which is not the usual position of the parathyroid gland. Here we have one in the mediastinum, and here we have one that is located retrosternally. Again, ectopic parathyroid gland, here we can see in the skull. It does not go beyond the base of the skull, but it is ectopic. And here again, we have in the mediastinum. This is shown by the PET-CT scan. Multiple parathyroid adenomas, so a lot of enhancement in multiple different places. Okay, now this is the normal I123 MIBG study for the adrenal glands. Okay, here it shows that there is pheochromocytoma of the right adrenal gland. So the right adrenal gland in this picture, it is enhancing. Okay, and here we have metastatic pheochromocytoma. So it's not, the enhancement is not only in the adrenal glands, but it is metastatic. Those pictures are really not likely to come. What's most likely to come, if you guys remember, is the picture of the hot and cold nodule of the thyroid. These are what usually come in the exam. Okay. Here we have recurrent paraganglioma. So paraganglioma is basically a pheochromocytoma, but outside the adrenal gland. So if the pheochromocytoma is in the adrenal gland, it's called pheochromocytoma. If it is in the outside the adrenal gland, it's called paraganglioma. Here we have a right-sided retroperitoneal paraganglioma that is resected 23 years back. This is the history. And here they can see the recurrence. Here we have neuroblastoma that is mostly seen in children. As you can see, we have enhancement in some areas in the bones as well. So this is a neuroblastoma that is seen in children. You can tell also from the picture that the patient is a child. Okay, these can come. This is a normal thyroid gland. This is a solitary large cold nodule. As you can see, the nodule here is not enhancing. Here we have multinodular goiter. Okay, here we have toxic multinodular goiter. And here we have multinodular goiter with a dominant large cold nodule in the left lobe. Next, we have the subacute thyroiditis. So here, when we did the uptake test, the uptake was really low. So there is low uptake. This means that there is degeneration of the thyroid gland. This is called subacute thyroiditis. In Graves' disease, طبعا, or toxic diffuse goiter, the gland would have a higher uptake. Sorry, this should be high, not low. So a high uptake of 13.9%. Normal uptake is 3.5. More than that, it's high uptake. Lower than that, this is low uptake. So what is the treatment? Radioactive iodine. Next, this is a scan that we did that is negative whole body scan. Here we have ectopic thyroid tissue at the base of the tongue, which is consistent with lingual thyroid gland. So sometimes this is a congenital problem that causes a thyroid tissue at the tongue. And as you can see, this is the tongue, and here we have a thyroid gland that is enhancing. Okay, now for the lectures with your other doctor, we'll start with the normal female anatomy. So here we have the uterus. It's important to note that here the inner lining of the uterus is the endometrium. This is the myometrium. And finally here we have the serosal layer. This is the vesicouterine pouch or the pouch of Douglas. This is the cervix, and this is the rectum over here. طيب. We have multiple ways to assess the female reproductive system. طيب, the most common and the most important is the ultrasound, and it's usually the first line. We always start with ultrasound. What are the strengths and weaknesses? You guys have had this a lot before. طبعا the strengths is non-invasive, does not require any needles or injection. It's safe, it's portable. However, it depends on the operator. It's operator dependent. And طبعا we have limited penetration. We have two types of ultrasound. Yes, we have the transabdominal, which is done on the abdomen, and we have transvaginal. Next, we have the CT, which is not a first choice for pregnancy. However, it's sometimes used for staging of gynecological malignancy. So when do we usually use the CT? In staging of gynecological malignancy. So the strengths, it has high resolution, provides clear, detailed images, and the weaknesses, it has radiation exposure, and sometimes people are allergic to the contrast. طيب, this is a picture that was in your slide. This is a simple ovarian cyst on computed tomography. So you can see that it's a cyst on the ovary, a very huge one. Okay, so this is a simple ovarian cyst on CT scan. Next, we have MRI. Again, MRI is very good for distinguishing soft tissue. Okay, however, contraindications, it's not suitable for patients with implants. It is very expensive. It takes more time than the CT. طيب, again, talking about the female's normal anatomy on MRI. This is the bladder, sorry, this is the uterus, as you can see, okay? And this is the bladder, and this is the rectum. Okay, physiological fluid is more bright on T2. If something was bright on both T1 and T2, that's most likely a tumor. So this is something you guys need to note. If I saw this fluid that is only bright on T2, for this is physiological fluid. As you can see on T1, it's not bright. If I saw something that is bright on both T2 and T1, for this is most likely a tumor. طيب, now for the positioning of the uterus, I need you guys to focus over here. If a female puts her hand on her stomach, okay, on her lower abdomen, when a female puts her hand on her lower abdomen, what she's touching directly is her urinary bladder. So the most anterior structure is the urinary bladder. طيب, behind the urinary bladder, we have the uterus. Behind the uterus, we have the rectum. طيب, so from anterior to posterior, we have the urinary bladder, uterus, and finally the rectum. I'm explaining this to you so that you guys do not يعني mix up between the anteverted and retroverted uterus. Okay, this is going to make it easier for you. طيب, هلا the uterus is in the middle, we said, anteriorly عنا urinary bladder, posteriorly we have the rectum. If the uterus that is in the middle was sitting on the urinary bladder, which is in front of it, for this uterus is called an anteverted uterus. However, if this uterus was sitting on the rectum, for this is called a retroverted uterus. طيب, how do I tell? Let's see in this picture over here. So this is the urinary bladder, this is the uterus, and here is the rectum. So this means that this woman is facing to this side, right? Because the urinary bladder is the most anterior. يعني, let me bring a pen. If this patient was pregnant, this is her belly. Her belly is facing this way. So first عنا urinary bladder, next عنا uterus, and finally عنا a rectum. طيب, let's go to this picture now. This uterus is sitting where? This is the urinary bladder. So this uterus is sitting on the rectum. So this is a retroverted uterus, right? Over here, this picture is not really clear, بس يعني you could tell that this is the uterus. طيب, this is the uterus. Here we have the urinary bladder. So you could tell that this uterus is anteverted, so it's sitting on the urinary bladder, not on the rectum. The doctor really emphasized on the positioning of the uterus. That's why I thought I would explain it more. I hope it's clear now. طيب. So the uterus is anteverted over bladder and anteflex in relation to the cervix. So this is an anteverted uterus. Again, it's sitting on the bladder. And this is a retroverted uterus. It's sitting on the rectum. Again, this is an anteverted uterus. This is the urinary bladder. The uterus is sitting on the urinary bladder. And this is on a transvaginal ultrasound. This is how the uterus looks like. طيب, it's important to note that in the early menstrual cycle, endometrium measures between 4 to 8 millimeters. In the secretary phase, it's going to increase from 7 to 14 millimeters. Postmenopausal patients should not have a thickened uterus. So postmenopausal patients should have a uterus of less than 5 millimeters, except if they are taking hormone replacement therapy. If they are on hormone replacement therapy, you could accept till 8 millimeters or sometimes 10, but not more than that. Okay, so in a premenopausal endometrium, it's important to note that in the proliferative phase, you can see this triple line appearance. So this triple line appearance is present in the proliferative phase of premenopausal endometrium. And here we have the thickened endometrium is seen in the secretory phase. But this is not abnormal. لا, this is normal in premenopausal endometrium, and it means that this woman is going through the secretory phase. طيب, let's talk more about these here. So we have three phases. We have the menstrual phase, the proliferative phase, and the secretory phase. In the menstrual phase, which is days 1 till 5, we have shedding, right? Here on ultrasound, we have thin, irregular, uh, can be seen, may see fluid or blood in the cavity. However, the endometrium itself is very thin, okay? Next, in the proliferative phase, we have a triple line appearance. So 1, 2, 3. You can see 3 lines over here. So this is the proliferative phase. Finally, the secretory phase. Here, the endometrium is the thickest that it can be. This is at days 15 to 28. So the thickest endometrium is seen in the secretory phase only in premenopausal women. طيب, now here, this if they told you that this woman is old enough, she's postmenopausal and she is having this kind of appearance, so this thickened endometrium, for this is called endometrial hyperplasia. طيب, next we have endometrial cancer. So we all know that endometrial hyperplasia can change into endometrial cancer, and those are of three types. We have endometriotic carcinoma, which is the most common, and we have serous and clear cell carcinoma. And this is where importance of MRI comes. It basically stages the disease. And sometimes you can also do chest, abdomen, pelvis, CT also for staging, okay? So these are the, this is how it looks on a CT and MRI. So you could tell that this is an irregular shaped lesion inside the endometrium. Okay, so those are irregular shaped lesions inside the endometrium. And here you can see on Doppler ultrasound that there is increased vascularity. So how do we differentiate between a polyp and carcinoma? طبعا they're all in the endometrium. This is a clear uterus and this is the endometrial line. A polyp is usually well circumscribed, right? So this is how a polyp looks like. Again, this is a well-defined oval-shaped structure inside the uterus. Here we have an ill-defined area with increased intensity. So it's ill-defined, increased intensity, and here as well, for this shows that this is an endometrial carcinoma. So next we'll be talking about uterine fibroids or leiomyomas. So uterine fibroids are benign growths originating from the smooth muscle tissue of the uterus. And we have three subtypes. We have the subserosal fibroids, which are basically at the outer layer of the uterus, if you guys remember. We have the intramural fibroids, which are located within the muscular wall of the uterus. And finally, we have the submucosal fibroids, and those usually, they're going to protrude into the uterine cavity. Let's see these together. Okay, so I have multiple pictures as you can see over here. So this is a fibroid that is protruding into the uterine cavity. So this is a submucosal fibroid. Again, this is a kind of polyp that is not protruding into the cavity. As you can see, the endometrium is actually covering it. It is inside the myometrium. So this is intramural. Same here, it's intramural fibroids. Again, here we have intramural fibroids. Here, as you can see, this fibroid is it's protruding outside the uterus, not inside, it's outside the uterus. So this is most likely a subserosal fibroid. Okay, same here. Okay, yeah, this is a Foley's catheter, this is the vagina, this is the fibroid. It's also protruding outside the uterus, so this is considered a subserosal fibroid. Okay, so the first line, of course, is ultrasound. In any pathology, the first line is ultrasound. However, MRI is needed to identify the number of fibroids, its localization, and its complications. Now, endometriosis. So we know that endometriosis is the implantation of the endometrial tissue, whether within the uterus or outside the uterus. If it's outside the uterus, it's maybe in the form of chocolate cyst, as we said in the pathology lectures. It could be hemorrhagic or endometriotic cyst. If it's inside the muscular wall, it's called adenomyosis. MRI is usually very sensitive in detecting endometriotic cyst because it contains hemorrhage. So here, as you can see, this is the endometriosis. This is outside the uterus. And again, I think this is the cyst that they're referring to. Okay, next we have this is again endometriosis, but this is inside the muscular wall, right? But this is called adenomyosis now, not endometriosis, since it's inside the endometrial wall. Again, this is here we have endometrial tissue that is inside the wall, so this is referring to adenomyosis. Next, we have cervical cancer. So you could tell that there is a kind of tumor or a mass at the cervix. This is actually running from outside to inside. It's invading the uterus. Here, this is at the cervical, right at the cervix from outside. Again, all of these are findings of cervical cancer. Type for ovarian cysts, it's important to note that there are three types of ovarian cysts. We have the functional cysts, which are the follicular and the corpus luteum cysts. If you guys remember, we said the corpus luteum cyst has this rim of yellow line outside grossly. We have follicular cysts that are seen on ultrasound, and those are called functional cysts. Okay? Then we have dermoid cysts and endometriomas. Now, what's also special about corpus luteum cysts in imaging is that it shows a ring of fire we see in the corpus luteal cyst. So, corpus luteal cyst has a ring of fire. In pregnancy, if the ring of fire persists for more than a few weeks, this is abnormal and we should investigate. So, let's take a look over here. This is a simple cyst. This is a cyst in the right ovary. It's simple. It's anechoic, no abnormalities seen over here. This is a complex cyst. How do I say this is a complex cyst? You can see that it is heterogeneous and there are kind of septa inside. This is the ring on fire corpus luteal cyst. It's an actual ring on fire shape. This is a polyp that is protruding inside I think this is a cyst that has a polyp, not a uterus. But again, it's a polyp and it's most likely cancerous because of the vascularity. And this is an endometrioma because of the echogenicity that is inside. This is called an endometrioma. Just memorize the pictures. Next, we have ovarian teratoma. So, as we know, teratoma is made up of multiple, can be made up of multiple stuff. So, it could be bone, tissue, whatever. So, this is a teratoma that has an enhancing lesion inside. So, this is how it looks on an MRI. This is how it looks here in this picture. It has fluid plus a kind of tissue inside. Okay, and this is on ultrasound. So those are pictures for teratomas. Next, we have the polycystic ovaries. You could tell from these pictures that the ovaries have multiple cysts over here, and they're usually peripherally arranged. Next, we have an ovarian torsion, which is basically an acute gynecological emergency. So what happens is that the ovary is going to be twisted around itself. So it's going to cut its blood supply by the ligaments, the vessels and the ligaments that are around it. Okay. What's important about this is that we have the whirlpool appearance. So the whirlpool appearance is the most important thing about the ovarian torsion. And this is how it looks on Doppler ultrasound. You could tell that there is a kind of circle around the ovary, which is causing this whirlpool appearance. And this is on MRI. This is the actual whirlpool appearance that is very clear over here. And again, this is how it looks on MRI. It actually looks like a simple ovarian cyst, I'm not gonna lie. But this is what the doctor mentioned, and these are pictures of ovarian torsion. Next, we have a kind of imaging called the hysterosalpingogram. So what this is that we insert a contrast through the endometrial cavity to identify the fallopian tube's patency. So we basically just insert the dye and it helps us see the shape of the uterus and the patency of the fallopian tubes. Okay, why is this important? Because sometimes we have fallopian tube blockage or anomalies that cause a different shape of uterus and fallopian tubes that is causing problem in fertility. Okay, an important thing to note is that the ampulla of the fallopian tube is the most common area for ectopic pregnancy. Type congenital Mullerian duct anomalies. We talked about this before. This is a normal uterus. This is how it's supposed to look like. However, we have different kinds of anomalies of the uterus. What's important to note is that the septate uterus has the highest chances of miscarriages. So a person who with a high chances of miscarriage, it's important to investigate for a septate uterus. Our arcuate uterus has the safest anomaly and has least chances of any miscarriages. Next, we have the gestational sac, early gestational sac. Guys, this is very important. The doctor emphasized on this a lot. So please memorize these. The signs of ultrasound in early pregnancy are three. You need to see all three. Number one is the gestational sac. If you guys remembered, we talked about that. It should look like an oval, right? And then we have the yolk sac, and then we have the double decidual sign. So double decidual sign is very important. If I only see this sac without pole or without the yolk sac, I should not call it a viable fetus until I see it again. I need to see the gestational sac with a double decidual reaction without the yolk sac, okay? And it's advised to repeat ultrasound after 2 weeks to assess for the interval development of the yolk sac. This is the double decidual sac sign. So this is a double decidual sac sign, and this sign plus yolk sac and gestational sac are clear signs of early gestational or early pregnancy. Next, we have the fetal pole and the CRL or the crown rump length. This is the most accurate sonographic measurement that can be obtained during pregnancy. So in the first trimester, if I have a gestational sac, I should measure the gestational sac diameter in 3 planes and then get the mean sac diameter. So it's important to get the gestational sac diameter. If the fetal pole has appeared, I should measure the crown rump length. Why? Because this is the most important measurement. So this is basically the total length of the baby, like in this image over here. This is the crown rump length. At 11 to 12 or 13 weeks of gestation, it's important to do the knuckle translucency, which is the measuring this area at the back, and this is important to exclude Down syndrome. At 18 to 22 weeks, we do the anomaly scan. In anomaly scan, all label structures should be evaluated. So anomaly scan is done at 18 to 12 to 22 weeks. Down syndrome or the knuckle translucency is done at 11 to 12 or 13 weeks of gestation. In the second trimester, we can do this kind of scan, which is a 3D or 4D ultrasound. This helps us in seeing the baby, him or herself. So as soon as you finish the first trimester, you start measurement of the biparietal diameter, femur length, abdominal circumference, plus placental localization. Why is placental localization is important? Because it's going to help us exclude placenta previa, which often presents as painless bleeding in the second or third trimester. Doppler ultrasound during pregnancy. Why is it important? It's important to identify or to evaluate the intrauterine growth retardation. We can measure the measurements. We can make the measurements of umbilical and uterine arteries. I think this is intrauterine growth rate. Because this is intrauterine growth rate. IUGR is intrauterine growth rate. I don't know why this is wrong over here. Okay, sorry for that. I'll double check. Okay. Now for multiple gestations, so as we said before, multiple gestations is when the woman is pregnant with multiple babies. So here we have 2 sacs, right? So this is amniotic. Here we have monochorionic, monoamniotic. We have 1 placenta and 1 amniotic sac. Here we have monochorionic, diamniotic. So this is 2 sacs and 1 placenta. This is the placenta over here. Okay, and طبعا we have conjoined twins. This is a picture for conjoined twins. Now for abortions, we talked about this before. We have missed abortion. We did not talk about missed abortion. A missed abortion is basically when there is a fetus, the fetus is there, however, there is no cardiac activity. And this is 50% due to chromosomal anomalies. So here on Doppler, you can tell that there is normal vascularity around the fetus, but inside there is no vascularity. But this is a missed abortion. In an incomplete abortion, we said that you can see the sac and some fluids inside, but there is no fetal pole. So you lose some so a part of the pregnancy, and here the cervix would be open. In complete abortion, you cannot find anything, and the cervix would be closed. Extrauterine gestational sac. This is when we find a gestational sac that is outside the uterus. So I think this is the uterus over here, and this is the endometrium, and here we have an extrauterine gestational sac. So this is basically another way of saying that there is an ectopic pregnancy. Molar pregnancy. We talked about this a lot by now. So molar pregnancy, we have the partial or the incomplete and the complete molar pregnancy. In the incomplete, the fetus is seen, as you can tell over here. In the complete, we have snowstorm appearance. So the scenario will come as a 42-year-old pregnant female presents with a uterus large for date and hyperemesis gravidarum. So the uterus is very large for the age, and we have hyperemesis, so we have increased need of increase nausea and vomiting. Beta HCG is very high. Transvaginal ultrasound shows hyperechoic soft tissue with cysts filling the uterine cavity and snowstorm appearance. This is molar pregnancy. And if you guys remember, we said if we did evacuation, we're going to see the grape-like structure. Heterotropic pregnancy. What is heterotropic pregnancy? It's basically when we have intrauterine and extrauterine pregnancy. This is called heterotropic pregnancy. طيب, MRI in pregnancy, it's not طبعا used routinely. However, sometimes it's used as a problem-solving tool when ultrasound is insufficient. So you guys can read the rest. I don't think it's important. طيب, what are factors? Okay, so we're done with pregnancy. Now let's move on to breast cancer. There are some kind of factors that increase the risk of breast cancer in females طبعا. Family history, early menarche, late first pregnancy, non-parity, late menopause, right? If women are genetic carriers of BRCA1 and 2 or other mutations, they are also more prone to breast malignancies. طيب, what are some diagnostics that are used for breast pathology? We have multiple. We have the mammogram, which is the most important. It's an irreplaceable tool unless the patient is too young. So if the patient is less than 30, we go with ultrasound. And why is that? If the patient is younger, this means that her breasts are denser because they have more glandular tissue. And here the mammograms cannot show the exact pathology. And ultrasound is needed. Next, we have CT. CT would be done for disease staging not related to breast pathology unless you are suspecting breast abscess, where ultrasound would be more than enough. Okay, so CT would be done for disease staging not related to breast pathology. Okay, unless you're suspecting breast abscess, here you can also do ultrasound. DBT, which is basically digital breast tomosynthesis, and finally we have MRI. So best tool for symptomatic patients, ultrasound if less than 40 or 30 years, and mammography if more than 40 years, followed by ultrasound if needed. This is how mammography is done. This is the craniocaudal view, which is used to compare each breast side to side, and this is the MLO view, helps us see the retromammary space and the space behind the pectoral muscle more clearly. So for screening, mammogram versus diagnostic mammogram. Screening mammogram is done in asymptomatic women, and it starts from the age of 40 to 45 to the age of 70 to 74. Diagnostic, it's applied on symptomatic patients طبعا, and the standard mammographic views are supplemented with additional views to further assess the screening detecting abnormality. طيب, breast anatomy on the mammogram. So as you can tell, here we have the nipple, here we have the duct. It's not a very clear kind of tool to see the anatomy. However, this is how it looks. The white tissue is the glandular structures and the black is the fatty area. A good mammogram can allow us to measure the distance from the nipple to the pectoral muscle. Now, one more thing that is really important to note and the doctor focused on is that the upper outer quadrant is the one with the largest amount of glandular tissue and is the most frequent site of breast cancer. So the upper outer quadrant. Next, lobes and lobules. I've put this picture just for you to note that whenever you see a fine linear branching calcifications, if the calcifications you're seeing on a mammogram are fine, linear kind of branching, so this is significant for ductal carcinoma. Next, after the mammogram, we have the DBT. So DBT, or digital breast tomosynthesis, can help identify pathologies by generating and reconstructing multiple image slicing. So again, it uses an X-ray source that is rotating. So you're generating multiple image slices that are then kind of built on each other, and this is helpful for patients with dense breast tissue. The images look a bit blurrier than mammograms, but the pathologies can be more clearly identified. How is that? This is a mammogram over here, and this is a DBT. As you can see on the mammogram, this patient has a very dense, not very, but a kind of dense يعني breast. So there is a lot of white lines over here. You cannot tell where the pathology is exactly. However, here in the DBT, the whitish glandular tissue is a bit slightly darker, making the the calcification to be more enhanced. Okay, so how do we confirm? طبعا we do biopsy. Next, we have the ACR by RADS density. So this is basically a classification that is made to classify the density of a tissue. So we have four types. We have A, B, C, D. So A, which is almost entirely fat, less than 25% fibroglandular tissue, and this is mainly in very old patients. B is scattered area of fibroglandular density, 25 to 50%. C is heterogeneous, and D is extremely dense. So this is a very dense tissue, breast tissue, and this is a fatty breast. So this is grade D most likely, and this is grade A. طيب. So here, as you can tell, the breasts are almost entirely fatty, so this is grade A. Next, here we have kind of scattered areas of fibroglandular density, this is grade B. Grade C, the breasts are heterogeneously dense, which may obscure small masses. And then this is the breasts are here the breasts are extremely dense, which lowers the sensitivity of the mammography. طيب. Now the BI-RADS also has made a kind of tool to do a final assessment, okay, for the lesion that is seen in the breast. Now, this is divided into seven actually. Zero, which means it needs additional imaging or prior examination. Your doctor actually emphasized on this a lot. I truly believe is going to give you a scenario or a picture and will ask you to use the final assessment category. So please focus on this. So again, we said we have seven types. Type 0 is the need of additional imaging or prior examination. Management require for additional imaging. Type 1 is negative. This is a routine screening. وخلاص, likelihood of cancer is 0%. Next we have is 2, grade 2. The category is benign. Again, for management, we do routine screening. Category 3, it's probably benign, but we do not know, we're not sure. So here we do short interval follow-up, so 6 months or continued. And then from 4, it starts to become suspicious. Here we do tissue diagnosis. And depending on the suspicion, we do biopsy and so on. Grade 5 is highly suspicious, and grade 6 is a known biopsy proven. Yani grade 6, we already know that this patient has breast cancer or breast lesion, and we're following up for surgical surgical excision. Okay, so this is a lesion that is seen over here. Now, this lesion is found in the at the behind the breast, okay? And it's not really clear according to the doctor. This patient presented with a mass on the mammogram at screening, which was assigned as BRADS 0. So what do you mean by 0? It means that it needs additional imaging or prior examination. Additional ultrasound demonstrated that the mass was caused by an intramammary lymph node, and the final assessment is BIRAD 2. So at the end, they reached a diagnosis of BIRAD 2. However, at the beginning, it was 0, which meant it needs more investigation. Now, grade 1 is negative. This is routine screening. For we did a screening, there is no classification, nothing suspicious. This is grade 1. So this is negative. Next, we have grade 2, which is benign. I think this is the lesion over here. It is well circumscribed. It's not enhancing, no calcification. But this is a benign lesion that just needs routine screening. Next, we have grade 3. Here, the initial short-term follow-up of BIRADS 3 lesion is a unilateral mammogram at 6 months. So here we can see a lesion. However, it does not look ugly. It looks kind of circumscribed. It's not really enhancing. So this is a probably benign. So what we do is that we just make follow-ups at a shorter interval. Next, after 1 year, when they did the follow-up, if a BIRAD 3 lesion shows any change during the follow-up, it will change into a BIRAD 4 or 5 because it is what it's growing, and this means that this is a malignant kind of lesion. However, if it did not show any changes and it stayed the same, it stays where it is. So the upper image shows a few amorphous classification initially classified as BIRADS 3. At 12 months, follow-up more than 5 classifications were noted, for this is changed into BIRAD 4. In BIRAD 4, as you can see here, it is it's not well circumscribed. It's pleomorphic. Pleomorphic classifications can be a sign of malignancy, for this is suspicious. For what do? We need to do tissue diagnosis, and this is divided into 3 types. Okay, and we have to do biopsy. Next, we have stage 5, which is highly suggestive of malignancy. As you can see, this is a very ugly looking kind of lesion. And we have a nipple retraction. If you guys noticed, we have nipple retraction over here. But this is a BIRADS 5 and highly suggestive of malignancy. More tall than wide with surrounding hypoechoic areas and mixed echogenicity, highly suspicious of malignancy. Next is the BIRAD 6. This is the known biopsy proven malignancy. Here we already know it's malignancy, and we're just following up to do new adjuvant chemotherapy and surgery. So the patient already has biopsy proven malignancy. Mammogram is done just for documentation purposes and to check other lesions or satellite lesions. Okay, now let's go through some pictures. This is a benign fibroadenolipoma. Okay, so this is a popcorn appearance, okay? Whenever you see a popcorn appearance on the breast, so this is a fibroadenoma. Why did we say here a fibroadenolipoma? Because surrounding the lesion, we have fat. So surrounding the lesion, we have fat or a black kind of structure. So this is fibroadenolipoma, and it's usually benign. Again, fibroadenoma, it's a popcorn-shaped structure, well-defined, hypoechoic, not anechoic, with edge enhancement on the side. If you see edge-to-edge enhancement, mild, no posterior enhancement on a hypoechoic lesion, it's not a cyst, it's a fibroadenoma. Okay, so this is talking on this picture over here. If you see edge-to-edge enhancement, so there is enhancement, but this is a fibroadenoma. Okay. A malignant lesion, طبعا it's a speculated dense mass lesion with some calcification, distorted parenchyma around the fatty parenchymal density and architectural distortion. Okay, so as you can see here on a speculated dense mass lesion, for these are all malignant lesions. Here we have posterior shadowing. So here we have the lesion and then we have posterior shadowing, and this is unlike cysts and fibroadenoma. This shows it's a malignant lesion. Again, irregular thick wall enhancing lesion, rim enhancement on MRI. Type. Now for the male breast. Here we have male breasts that are showing kind of increased density. If there is increased density for a male, we have to evaluate a possible gynecomastia case. Remember, guys, I told you that in gynecomastia, it's important to note that the lesion is subareolar. So as you can see here, we have subareolar, increased density, flame-shaped appearance, and sometimes present with breast enlargements. So these are signs of ish. These are signs of gynecomastia. Okay, nodular pattern of gynecomastia, as you can see over here, and this is the nipple, so this is subareolar. Again, this is the nipple subareolar kind of lesion. And again, this is a malignant lesion. Again, it's a speculated with dense margins, but in male. So this is a malignant lesion in a male breast. Architectural distortion. This is a picture of architectural distortion. It's basically a breast imaging finding on mammography on ultrasound MRI where the normal breast tissue structure is disrupted without a clear mass. يعني I cannot locate a clear mass over here. I cannot locate a clear calcification. There is just a distortion in the picture. Okay? Here as well, there is no clear calcification, no clear mass. So this is called an architectural distortion. And usually they, depending on how it looks, they can sometimes excise it or take a biopsy, and usually it turns out to be normal breast tissue. Phyllodes tumor. Phyllodes tumor is large and has core calcification. If you guys remember the pathology picture for it, it's very important. It had a kind of like pyramid shape in the middle. Phyllodes tumor, large and have core calcification. Memorize the picture, please. Next, we have the hamartoma, which is a disorganized overgrowth of benign mammary tissue within cells, and it appears as typical sausage shape or piece of salami appearance. So typical sausage shape. As you can see over here, we have the sausage shape. Whenever you see sausage shape here, think about hamartoma. However, here you can see that there's a kind of hemorrhage or a kind of cyst that contains hemorrhage. So these are all kind of hamartomas. Next, we have a lipoma. بصراحة I can't tell exactly where the lipoma is here. Just memorize the picture. If he gets you this picture, this is lipoma. Next is an abscess. Abscess would present with fever, redness, and pain. So a scenario of patient with fever, redness, and pain, and those pictures over here, irregular masses that are sometimes enhancing, sometimes like having like fluid filled, they're not empty. So this is an abscess. Now, this is a breast with surgical clip. The hyperechoic bars are basically surgical clips, but the small hypoechoic density around them can be easily misinterpreted as BIRAD 5 or 4, so histo or biopsy is needed. MRI, when do we use MRI for breast tissue? Its main advantages is that it has non-ionizing radiation. Of course, and we talked about the disadvantages, they have longer scanning times and so on. طيب, now for breast implants, this is the final part of our lecture. In the breast implants, we have two types. We have the subpectoral. As you can see, this is the line of the pectoral muscle. This is subpectoral breast implant, and this is prepectoral breast implant. This is the pectoral line, okay? This is the pectoral muscle line. So this is prepectoral, and this is the subpectoral. Okay, subpectoral, so under the pectoralis muscle, prepectoral, which is يعني in front of it. And this is preoperative. Now, there are some cases of rupture implants. Here we have extracapsular rupture, so the rupture is outside the capsule, and we have here intracapsular rupture. This is where the rupture is inside the capsule. Now, the final slide from your radiology lectures is this one. The doctor did not elaborate much on the procedures and he even skipped those slides. However, just know that we have three types of important procedures. We have the fine needle aspiration, we have the core needle biopsy, and the vacuum assisted biopsy. And that's it. The vacuum assisted biopsy uses suction to obtain larger biopsies than the core needle biopsy. And that's it for your OSP. I really hope you guys benefited. If you have any questions, feel free to contact me. These are my contact info. And good luck on your exam.